Hi guys, today's topic about surgical management of OSA. See this patient having classical OSA of grade 3. What is obstructive sleep apnea? This is brief about obstructive sleep apnea. This is cessation of breathing during sleep from partial or complete narrowing of airway. It is classically present with tired, chronic snoring, excessive daytime sleepiness, and witness apnea by tell by neighbors or somebody closing sleeping with you. That is witness apnea. And OSA comes under the sleep disorder breathing. There is two type of sleep disorder breathing. One may be abnormal rhythm, second may be abnormal gas exchange. If you see abnormal rhythm, there is first is OSA, second is central sleep apnea. If upper airway obstruction is there, that is OSA, and there is in central sleep apnea, there is Chinese stroke breathing or brainstem dysfunction, maybe opioid abuse, or maybe mass in the brain, or maybe brainstem tumor. This difference between OSA and CSA is mainly effort. Breathing effort is absent in obstructive sleep apnea, but in central sleep apnea it is present, and saturation airflow drop in both. Where is abnormal gas exchange having hypoventilation or hypoxemia with hypoventilation, mainly in COPD, obesity, or neuromuscular disorder. We are not talking about this. If you see the pathophysiology of this cyclical collapse of pharyngeal airway, resultant apnea or hypoapnea, leading to hypoxemia or loss of muscle tone. If you classify this OSA grading according to apnea hypoapnea, 0 to 5 normal, 5 to 15 mild, 16 to 30 moderate, more than 30 is above severe, with bothersome chronic snoring and excessive daytime sleepiness. So this clinical should be present with this apnea hypoapnea index. Now, prevalence of obstructive sleep apnea about 10 to 25% of the population. Incidence about 13% of adult male and 6% of adult female. About 18% are undiagnosed. What are the risk factors of obstructive sleep apnea? Mainly obesity, age more than 50, male gender, it's common in male than the female. Thick neck, retrognathia, crowded airway, narrow throat, enlarged adenoid or tonsil, or smoking and alcohol, or patient having fatty habits of food. If you see sleep pattern, 75% of non-rapid eye movement sleep, 25% of rapid eye movement sleep. So this sleep, mainly non-rapid eye movement sleep, is deep restful restorative sleep. What is simple snoring? Vibration of soft tissue OSA during sleep. It increased by the tobacco, alcohol, and smoking, but it's not pathological. What is symptomatic? Poor memory, feeling tired, frequent visit of toileting, lack of concentration. These are the symptoms. Why should treat OSA? It's prevent the CVS collapse. It prevents CNS disease. Quality of life should be improved. Driving safety and better brain functioning. So we have to treat sleep apnea due to these reasons. If you see this graph, mainly OSA between the 15 to 20 year of age because of adenoid and tonsil, 8 chances increase after 40, about 32% having OSA, mainly men having 40% after 40, or women having 24% after 40 or 50. So this graph suggests there is two peaks in children's and adult after 40. If you see OSA airflow, this suggests if there is apnea episode with falling of saturation less than 94%, or episode of apnea or hypoapnea more than 10 seconds, multiple episodes are there, and there is respiratory effort related arousal in between the sleep, which suggests there is obstructive sleep apnea is there. Now mainly diagnosis. The sleep apnea main diagnosis is clinical, aided by drug induced sleep endoscopy, polysomnography, and sleep and dynamic MRI. If clinical, you see are so many parameters. First is stop being questionnaires. So you should ask about snoring, tiredness, blood pressure, BMI more than 50, age more than 50, BMI more than 35, age more than 50, neck circumference more than 40 centimeter, or male 17 inch, or you can say female 16 inch. Gender male is more common. If you see ambulatory stable obese patient, if you do ABG, if serum SO3 less than 27 is there in obese patient, there is OSA is highly unlikely. And if it is PCO2 more than 50 or SCO3 more than 25, you should proceed for polysomnography and DICE. A Friedman palate positioning scale. Entire uvula seen, that is grade 1 or with tonsil. Grade 2 is only uvula is seen. Grade 4 is soft palate seen or uvula seen, and grade 4 is hard palate seen only. Now, if our sleep is scoring, it not should not be done on medication patient. If you see there is dozing during sitting and reading, watching TV, sitting in an active place, long trip in car, sitting and talking to someone, sitting after lunch, and driving and stop at traffic light, and lying down at rest in the afternoon. So this is the average sleepy snore. If it is 0 to 7 normal sleep, if it is 8 to 9 average amount of daytime sleep, 10 to 15 excessive sleep should rule out OSA, and 16 to 24 there is confirmation of OSA with further evaluation is needed. If you talk about this IBAR sleepiness score, it tell about dozing, maybe 0, never doze, 1 slight chance of dozing, 2 is moderate chance of dozing, and 3 is high chances of dozing. So this is all about dozing. If you see weight increment with the OSA chances, if 10 kg of weight of increase individual, there is 6% of chances increase of OSA. If 20 kg increase, there is 15% chances of increase of OSA, and 30 kg increase, there is 30% chance of increase of OSA. Now, drug induced sleep endoscopy. It mainly assesses the airway in complete sense, location, area, and pattern of airway collapse, and it is done with midazolam, dexmedetomidine, and ketamine or propofol only. If you see there is, you can assess by boat classification or N-boat model. According to it, you assess the different type of pattern of collapse in velum, oropharynx, tongue base, and epiglottis. Better is second classification, you can say N-boat model with nose, velum, oropharynx, tongue base, and epiglottis. This classification doesn't exist, but you can see on sleep endoscopy where is collapse. You should not operate concentric configuration of collapse because it's very bad to operate, there is no results. Now polysomnography or dynamic MRI. The dynamic MRI is equivalent to DICE. You can see complete evaluation of soft tissue collapse during sleep. Now polysomnography. It is proposed by Holland, Dement and Renan in 1974. It is comprehensive recording of biophysiological changes that occur during sleep. For me, there are multiple parameters like EEG, EOG, electromyography, electrocardiography, respiratory channel, and pulse oximeter. There are 7 channels, but for OSA there is 2 channel is very important. Respiratory channel like airflow and effort, and pulse oximetry which tell about O2 saturation. So these two parameter, if saturation fall more than 4% and SpO2 fall more than 90%, then you should think about it is disturbed sleep or it is OSA. Now, management of OSA. If it is mild OSA, EHI less than 5, DIAS or dynamic MRI showing mild collapse, and PSG showing more than 94% PO2 saturation are maintaining, that is this patient of mild OSA not required any further management, only regular exercise or a spectrum management. Moderate OSA, if it is EHI between 5 to 15, bad MRI or DIAS or single level, mainly you can prescribe CPAP or beat reduction exercise. If severe OSA is there, HI more than 30, DIAS or MRI showing multiple or bed collapse, not managed by CPAP, and PO2 less than 90% fall during the sleep. So these patients required some added management like surgery and CPAP both, or sometimes surgery only. It's tailor mode approach only, which patient require what, it depend on the individual collapse or individual pattern of obstructive sleep. The surgical management mainly upper airway surgery, neurostimulated device, bariatric surgery, maxillofacial mandibular surgeries. So these are the surgery. This is the brief about OSA. So this management is depend with individual patient, and this lecture I made only for basic about obstructive sleep apnea. So anybody can operate these cases, but selection of patient is very important. You should not operate patient which is BMI more than 40, because if you are pulling peanuts from the rock, so it's not going to improve, because we have to assess complete patient. So concentric collapse or BMI more than 40 are non-operated. According to me, they are contraindicated because they are not supposed to help by any mean. If severe OSA is there, you can go for tracheostomy only. So
Obstructive
these are the
sleep apnea
management.
case,
Thank you
male
so much.
40, come to me with nocturnal breathing difficulty with repeated episode of awakening during night. This is OSA characterized by the increased nocturnal airflow resistance with repeated episode of pharyngeal collapse during sleep. As you can see this in this case, this nose is absolutely normal, but this patient having nasopharyngeal obstruction, mainly lateral wall collapse with large tonsils. So in this case, I have done bilateral tonsil collateral tonsillectomy with strip palatoplasty and uvuloplasty. I have removed 6 to 8 strip, horizontal strip, midway between the this hard and soft palate, so that this strip can be resutured and the nasopharyngeal velopharynx can be open up. So you can see this large nasopharyngeal intubation and the space created, and I'm doing this strip. You see, I'm removing the strip of palate so that I can research, and after 4 weeks it seemed to be normal, absolutely normal, and the space is open up. And you can see this bilateral tonsillectomy, and to suture laterally I am putting to pull out the lateral wall laterally so that it will open up completely. For OSA, three investigations are very important. One is drug induced sleep endoscopy, second one is dynamic MRI, or you can say sleep MRI, and third one is polysomnography. So this case I have done recently today only. So this is all about obstructive sleep apnea. Thank you so much.